We've now come to the live Q&A of the first session. At this point, we'd like to invite Dr. Lim Hwee Yong, medical oncologist, as well as Dr. Lee Kuo An, radiation oncologist, to moderate our Q&A session with our speakers from the very first session, Dr. Kwek, Dr. Chan, and Dr. Yap. Over to you, Dr. Lim, Dr. Lee. Stage is all yours.
Thank you very much. Maybe I'll ask the first question to Dr. Chan. Which patient do you think should be started on some kind of prevention like ACE inhibitors, ARB, or beta blockers for primary prevention of cancer therapy related to cardiac dysfunction prior to starting cancer treatment?
Yeah, so I think in the talk I mentioned, when we do a baseline, when we see the patient, it's important to do a baseline cardiovascular risk assessment. So as per what I've gone through, there are quite a few things that the guidelines, the recent ESC guidelines has recommended. So once we assess the risk, we know which risk profile they belong to. So in the high and very high risk group, so this group of patients prior to starting chemotherapy medications that can put them at risk of cardiovascular or LV dysfunction, then we do need to consider starting them on ACE inhibitor or ARB and beta blockers. Yeah.
So I have a question for Dr. Kwek. In this era of targeted therapy where the drugs are so specific, and you can get fantastic responses with not much side effects, you can never quite fully predict it. But if you do find a drug target when you do your next generation sequencing, I understand from this year, many of these drugs will no longer be approved for payment because they may not have been tested in that specific cancer, even though we know that in your particular patient, they do harbor a mutation that makes that drug a potential predictive drug. Yeah. How would you get around this problem, or what do you think can be done?
So this is a very tough question and a very good one, Guan. I see it as two components. The first component will be what is already well recognized within the cancer itself. So you do the mutation testing to allow for first-line treatment. And many of these first-line treatment, as you have mentioned, are approved locally and within the cancer drug list and are indicated for use and is reimbursable by insurance. There's another group which is usually more later lines of treatment. These are the more end-of-the-road patients whom we are trying to find a novel, less predictable target for which there may be a drug available, a commercially available drug. And for this group of patients, they may be affected because it is not approved for use in the indication, not approved for use on the CDL. And for this group, we seriously and need to wait for the advisory coming out from the insurance industry by the end of this year. There will be some changes to our insurance coverage in terms of riders, in terms of what's covered and what's not covered, and we await more news. We hope that the news will be positive for all of us and all our patients.
Thanks.
Okay, maybe I'll follow on with the question to Dr. Kwek. So in this day and age, with new technology, what do you do in your practice? Do you check everyone with liquid biopsy, whole genome sequencing for everyone that first presents to you, or do you do it after the first line, treatment?
Okay.
Yeah, when do you do it, and how often would you repeat it?
Okay, so good question, Hwee Yong. Thanks for that. So in essence, my practice mirrors the guidelines very closely. So if you have some of the common cancers, which including lung, breast, colon, for example, and there's a standard panel which we will typically do. So the breast will include ER, PR, HER2 status. The colon will include KRAS mutation in a metastatic setting, BRAF, even NTRK. So there's a fixed panel, and these are meant, at least for the colorectal cancer patients, meant for stage 4. Similarly, for lung, there's a panel of testing that allows us to initiate first-line therapy. Now, some of us do liquid biopsy, and it's actually advised in some of the guidelines to be performed at time of progression. So a liquid biopsy essentially is a blood draw to look at changes in the cancer mutational profile that has evolved with the advent of drug therapy. So it's under drug pressure, things change, and you're looking for what the changes are. And in many cancers, this is advised, in particular lung cancer, to look for secondary mutation. Do we practice that? Yes, of course we practice that. Now, to link it up with Guan's question is, can we change therapy after we find these mutations? So that one remains to be seen, what is going to be covered, what's not going to be covered, and certainly we want to watch that space closely.
I have a question for Dr. Yap. I've always found it a bit puzzling that as people get older, the incidence in the age group of cancer rises. And yet for the screening recommendations, once you pass a certain age group, the recommendation becomes to stop screening. Sounds a bit like a paradox. Is that any way to get a head around how to understand why once you pass a certain age group, the recommendation is to stop screening?
I guess this is based on research and also on the cases that have been collected so far. It appears that for it to be cost effective, we are talking about category 1 cancer screening, then there is a need to find out which age group is the best time for cancer screening to be recommended. So for instance, like we take age 40 as a cutoff. For those who want to ensure that they do not have problem with the breast cancer, you want to begin from the age. And for those who are 50 and above, colorectal screening is important because based on studies, it is much higher above the age group. The same goes for the other cancer, like even the cervical cancer, for those who are sexually active above the age of 25.
Are any of these covered by, or does patient have to pay for it by themselves, or is there any government subsidy?
Yeah, I think in my talk I did mention about Screen for Life. So for those who are 50 and above, colorectal cancer screening, the FIT test is provided for. And for those who are female, who are 25 and above, they can do pap smear. And if they are above 30, they can do DNA screening. And there's a HPV DNA screening. And they only need to pay $5, which is very affordable for Singaporeans.
Thank you.
Maybe I'd like to ask Dr. Chan a question from the role of primary care physician. I understand from your talk that the risk of cardiovascular events is much higher for cancer survivors. So maybe you can advise primary care physician, what should we be looking out for when they come to see us?
Yeah. So I think now we are more aware, and the population of cancer survivors is actually increasing with proper treatment and more and more people surviving from their cancer. So most times when patient goes through treatment, chemotherapy treatment, there are side effects that we have mentioned about that's associated. So I think what's important is that when past the completion, within the 1 year actually past the completion, we are actually more on higher alert in that sense. There's certain screening protocol that I've gone through in my talk. But beyond that as well, lifelong, actually a lot of these patients have got significant cardiovascular risk. So not much difference from the usual cardiovascular guidelines is that we screen for cardiovascular risk factors, diabetes, hypertension, hyperlipidemia. Weight is an important issue as well in that sense, as we have spoken about in my talk. And also the important part, I guess, in this group of patients is that it is good to have some understanding, although sometimes not always easy, of what kind of treatment that they have received in terms of chemotherapy treatment, radiation therapy, because with different treatments comes certain side effects with the treatment. So it's good, I think, for all of us in healthcare to have some sense of that. So not always possible, but if there's a chance of knowing what kind of treatment they've gone through, and more importantly, if they have sustained cancer therapy related cardiotoxicities, then take it from there, be a bit higher risk. And important thing, I guess, is as general, we do an ECG. And then if there's any new symptoms clinically, then we have a low threshold at referring to a cardiologist for further evaluation.
Okay, thank you.
Okay, we have one last question. I would like to ask Dr. Yap as well. It's very exciting to see that you're trying to do a lot of cancer prevention, obesity, smoking, alcohol, even getting your patient to kind of enroll on a exercise program. Can I ask you, in real life, how do you approach it? Let's say, they usually come together. An obese patient who smokes heavily, drink heavily. How do you approach it, and how successful are you in doing this cancer prevention counseling?
I found that the statement, how to square off the curve of a patient, very helpful for me. So for every patient that comes to my practice, I ask myself, can I square off this person's curve? In other words, can I delay the onset of diseases, whether it's chronic diseases or cancer, as long as possible, so that upon detection, you'll be towards the end of their life, so that we actually compress morbidity. So in other words, we actually help patients to live healthily as long as possible. So when patients come to see me, I would check their blood pressure, I would check their weight to make sure that they are within the healthy range. If they are not, then I would share with them the importance of maintaining a healthy weight. And I would advise them just by cutting down 5% of their weight, if they are overweight, will be translated to a lot of health benefits. And sometimes I would share my personal example, how I squeeze out just 7 minutes, the scientific 7-minute workout. And that is something that's doable, which I do before I take my shower after I come back from work. And I find that very helpful. Yeah.
Okay.
Okay, yeah.
Yeah. So I think we've come to the end of this segment. So we'll pass it back to MC.
Thank you very much, doctors. A very engaging webinar indeed. And a big thank you to our speakers from the very first session, Dr. Kwek, Dr. Chan, and Dr. Yap, as well as our moderators, Dr. Lim and Dr. Lee. Do stay on the webinar with us as we get ready for the second session of our webinar with more medical insights from our medical specialists. We'll see you soon.